I'm very pleased today to introduce the symposium that is a joint symposium between ESCEO and IOF on a new technology that is called radiofrequency echographic multispectrometry. And this is a new technology that will make possible in the future to measure bone quantity as well as hopefully bone quality aspects in a way that will give us the opportunity to evaluate the status of bone health in our patients. And with this, I just want to thank my co-chairman, Professor Adolfo Diaz-Perez, to chairing this session with me today.
Thank you very much, all three speakers, for the outstanding talks. We have been illustrated on the potential of a new technique for the assessment of bone strength, the radiofrequency echographic multispectrometry technique. And this technique is very advantageous for some important points to remember. It's user-friendly, it's radiation-free, it's portable, and offers us the opportunity of measuring bone density in a very regular and reproducible manner, as we do with the currently available techniques widely expanded. But on top of that, there are new developments of this technique that promise us important advantages and information for the clinical estimate of bone health and make a good point for basing our decisions in the clinical ground. Both the developments of the estimate of bone strength beyond bone density, as well as new opportunities for the assessment of muscle and muscle health in our patients that very often have together osteoporosis and sarcopenia, are important and exciting new horizons for our clinical practice that for sure will be extremely useful for us as a clinician and very helpful for our patients. Thank you very much for attending this symposium.
Dear colleagues, bone strength is characterized by four main characteristics, namely bone size, shape, architecture and microarchitecture, and its material composition. Each of these main characteristics is determined by different factors. For example, trabecular architecture itself is determined by trabecular number, trabecular thickness, the shape of the trabeculae, and their connectivity. Currently, a large number of different tools is available for estimation of bone strength, either indirectly or more directly. These tools comprise imaging methods, laboratory methods, fracture risk assessment tools, trans-iliac bone biopsy, and even more exotic tools, such as reference point indentation, for example. DEXA certainly is the most widely used technique. It has been shown that aerial BMD, which is the outcome of DEXA measurements, accounts for about 2/3 of the variance of bone strength, although this has only been shown in vitro on isolated bones so far. The advantage of this tool is that those skeletal sites which are most vulnerable to fracture can be directly measured. It is mainly used to assign a person to one of the WHO diagnostic categories, such as osteopenia or osteoporosis, to get information on an individual's future probability to fracture and for monitoring purposes. TBS, Trabecular Bone Score, is a software package that is available for DEXA machines, and meanwhile it has been installed on many machines worldwide. It is based on different grade levels of pixels that are generated by DEXA images. The different grade levels reflect differences in trabecular bone mass. The less bone, the darker the pixels. In that sense, TBS provides information beyond that captured by standard BMD measurement. For example, in women with diabetes, BMD has been shown to be higher compared to the healthy controls. Paradoxically, this higher BMD is associated with a higher risk of fracture. Now, TBS has been shown to be lower in women with diabetes, indicating that it captures at least part of the fracture risk associated with this disease. Another tool to get information on bone strength is hip axis length. It is defined as the distance from the base of the greater trochanter through the femoral neck to the inner pelvic rim. It has been shown that when adjusted for age and femoral neck BMD, each millimeter increase in HL increases hip fracture risk by 3.6% in men and 4.6% in women. Hip structural analysis is another software tool designed for DEXA machines. It is extracting geometric information from pixel data, such as surface dimensions and bone cross sections and other linear dimensions. In that sense, it is providing information on cross-sectional areas, cortical thickness, and also, for example, the buckling ratio, which is the ratio of the actual load to the load at which buckling of the bone would occur. QoS is one of those tools that work without radiation. This is certainly an advantage. Parameters that are obtained are the speed of sound and broadband ultrasound attenuation. SOS simply provides information on the velocity of the ultrasound waves, and BUA captures the attenuation of the ultrasound waves when transmitted through bone. A combination of SOS and BUA is called stiffness index and quantitative ultrasound index. Well, in a larger number of clinical studies, it has been shown that QoS correlates moderately with BMD from DEXA, that it is an independent risk factor for fracture, that it is associated with hip fracture, that it discriminates subjects with fractures from subjects without fractures, that it is a better predictor of hip fractures than spine fractures, and that it has a similar sensitivity as DEXA, but lower specificity. Quantitative computed tomography has been shown to be an alternative to DEXA, at least in some cases, for example in patients who are very small or large or very obese, or in patients with advanced degenerative changes at the lumbar spine, and also for treatment monitoring if response needs to be detected as early as possible. Single slice QCT has been established for BMD measurements at the lumbar spine. Usually, single sections of 3 to 4 consecutive vertebrae are scanned. Some studies have shown that specific thresholds expressed as milligrams of mineral per milliliter of bone correspond to the WHO categories as used for DEXA. However, the WHO categories should not be used for tools other than DEXA simply because these categories have been derived from DEXA data and nothing else. Compared to single slice CT, volumetric QCT provides increased precision. Typically, 2 lumbar vertebrae are measured. The radiation exposure dose, of course, is far higher compared to the single slice tool. The thresholds published for this device allow to assign a patient to 1 or 3 degrees of fracture risk, namely mild, moderate, or severe. QCT can also be used to perform finite element analysis. The finite elements are based on voxels, and each element is then assigned specific material properties. Fairly complex algorithms are then applied to determine the load at which structural failure would occur. This is just one example of a prospective controlled FEA study. The authors defined thresholds which would correspond to osteoporosis and osteopenia according to WHO criteria. And they called these thresholds fragile bone strength and low bone strength, respectively. HRPQCT, high resolution peripheral QCT, is indeed a fascinating tool in that its resolution goes down to 30 microns, which is roughly equal to the diameter of just 4 rhabdocytes. Thus, this tool is providing a sort of virtual bone biopsy. There is a whole myriad of different parameters that can be derived from HRPQCT. For example, trabecular number, trabecular thickness, cortical porosity, the shape of the trabecula, like plate-like or rod-like, and many other parameters. The current versions can perform measurements at the distal radius and the tibia, but more advanced versions are under development. Again, just as an example, the findings from a prospective clinical study which was performed in men with a follow-up period of 8 years. The authors found that trabecular number of the distal radius was most strongly associated with higher fracture risk even after adjustment for possible confounders such as BMI, age, force fractures, etc. Now, reference point indentation is a real novel microindentation method that can be used to assess mechanical properties of bone, both in vivo and ex vivo. In human subjects, the measurement site is usually the tibia plateau simply because it is readily accessible. It has been shown that the indentation depth correlates well with bone strength, but so far no large-scale clinical trials have been published, and hence its clinical relevance cannot be appraised at this state. Magnetic resonance imaging certainly is an interesting tool, and I think it's worth mentioning that it is free of radiation. At least it provides a more or less indirect signal for bone, as the bone marrow, in fact, is the compartment that gives a hyper-intense signal. Similar to other tools shown before, finite element analysis software has also been developed for MRI. For example, in a smaller cross-sectional study, it was shown that subjects who had experienced a fracture had a significant higher disruption of trabecular rod-like structure compared to controls. However, there's no doubt that the biggest limitation of this tool certainly lies in its extremely high cost. And last but not least, I would like to mention a tool which has been brought to the market only recently. It is called Cortical Bone Mechanics Technology, and in fact it is an in vivo 3-point bending test tool that is applied to the ulna. The outcome parameter is called EI, which is the product of the elastic modulus and the cross-sectional moment of inertia. However, currently larger scale trials are not available, and we will see if this tool will play a significant role in the future. Now, in summary, at this state, the DEXA method, with or without TBS, certainly is the most widely used tool for the assessment of bone strength. Limitations of most of the alternative tools are their limited availability, in some cases a higher effective radiation dose, a longer duration of the procedure, and of course higher costs such as for MRI. Now, that being said, there are several unmet needs that have to be considered for future technologies. For example, a broader availability in routine clinical settings, avoidance of underdiagnosis or late diagnosis, estimation of bone strength in pediatric subjects or in pregnant and breastfeeding women, and finally an improved response rate during treatment, just in order to reduce follow-up intervals. I thank you for your attention.
Good morning to everyone, dear friends. This is my task as the first speaker of this symposium on RAMS to give a brief overview on the role of bone strengths in the assessments of fracture risk. Here are my disclosure. In the following 15 minutes or so, I will go through the current technology we use to evaluate bone strengths and what we may have in the near future or so for looking at this very important parameter. And the first slide I would like to comment is this very interesting study published a while ago by Tom Keaveney and Mary Boxen, because in this slide there is a very simple clinical definition of how bone strength is important, and that's what they call the phi ratio, namely the ratio of load to strength, with a very simple theoretical biomechanical fracture threshold to deal with. As when load is higher than the bone strength, then you get a fracture. Therefore, this fracture threshold is just 1. If the phi ratio is above 1, then you get a fracture. If the phi ratio is below 1, then the bone remains intact. And as you can see on the graph on the left-hand side panel, for a patient who have a very low strength defined by FEA, around 1500 to 2000 Newton, you can see that the phi ratio is way above the threshold of 1. But for patients that have a moderate bone strength in the range of 2,000 to let's say 3,000, you may have situation in which the ratio is above 1 or below 1, depending on of the load, and that's one of the critical explanation why it is very difficult in clinical practice to define this bone strength. What is also very interesting with this phi ratio is that it gives you a good explanation for the response to treatment that do not need to increase tremendously the bone strength to decrease the risk of fracture. In fact, if you plot the baseline phi ratio to the 24 months phi ratio in this past study evaluating the effect of teriparatide as an example, if you increase the bone strength just enough to bring this phi ratio, which is just above 1 to just below 1, then you definitely decrease the risk of fracture. So far, the main technology we use is the evaluation of bone mineral density using DXA. And in the couple of following slides, I will show that actually BMD measured by DXA is doing pretty good for evaluating bone strength. If you compare, for example, as this study conducted in Reykjavik did, if you plot the BMD T-score to femoral strength, you see that there is quite a good correlation of these two parameters. And you can also easily see that you can have a kind of a threshold below which, or on the left side of which, most of the cases with fracture in this case control study occur, while when patients are above this threshold or on the right side of the threshold, you almost have no case of fracture. This threshold is probably around minus 1.5 to minus 1.7 in this study. Another aspect of the interest of BMD evaluation is that it has been very well demonstrated that one BMD assessment is very good to predict the risk of fracture, but we now have data showing that this ability of predicting fracture is actually very good for a very long period of time. And in this evaluation drawn from the study of osteoporotic fracture, the SOFT study, the author were able to demonstrate that this probability of predicting fracture was actually very good for a 25-year period, at least for the hip fracture. And as you can see on the on this panel, while there is not a big difference with different age telltale in this graph, you can see that with a decreasing BMD, the prediction of fracture tremendously increases for this very long period of time. So we have quite a good marker, and this marker is good for predicting for a long period of time, even if you just perform one single BMD measurement. What we also learned in the in the past years is that the change in total hip BMD is also well correlated with the decrease in the risk of fracture under treatment. This has been shown with DMAB in the FREEDOM study, as you can see on the left panel, and it has been shown also in the HORIZON study with ZOL. And what was interesting in both studies was that the correlation between DMAB, the changes in BMD under DMAB, and the decrease or the changes in the risk of fracture and the treatment was very similar to the same correlation and the placebo, suggesting that the changes of bone strength and the treatment was very much correlated with the changes in bone mineral density. And this observation was more recently made in a very large meta-regression of 38 placebo-controlled trials. I will go just briefly through that very nice work published by Murray Boxen, coming with the conclusion that for a given change in total hip BMD, you might expect a given reduction in hip or vertebral fracture risk. But coming back a minute to the work of Tom Keaveney, while there was quite a good correlation between aerial BMD and strengths calculated by FEA, actually, what is the problem? The problem with BMD is demonstrated in the right-hand side panel with this plot of phi ratio to aerial BMD. If you use the different definition range of normal BMD, osteopenic BMD, and osteoporotic BMD, you can see that, of course, for all osteoporotic patients, the phi ratio is much above 1. For those who have normal BMD, the phi ratio is below 1. But for this range of osteopenic patients, you can see that there is a large proportion of patients that do have a phi ratio above 1, meaning that if they fall on the side, the bone will not be strong enough to not fracture. Therefore, investigators have been looking at different other technology to better discriminate patients that have an osteopenic BMD value to predict their risk of fracture. And actually, high resolution PQCT one of these very interesting technology, and some of the parameters assessed by PQCT were able to better discriminate patients with osteopenic BMD at high risk of fracture, or those having a fracture compared to those having no fracture. But even though it did improve this production, this very elegant study from Emmanuel Beaver, looking at the Geneva retirees cohort in Switzerland, demonstrated that although failure load calculated using PQCT did improve the fracture prediction compared to age and femoral neck RL BMD on the left, or Frax BMD on the right. Actually, if you add to these parameters ultradistal RL BMD measured by DEXA, you got information that were quite comparable to what PQCT did, and of course that's a much simpler way to get this information. PQCT might actually be quite interesting in specific circumstances where BMD is not that good to predict the risk of fracture, and that's the case of glucocorticosteroid-induced osteoporosis, as shown in this recent case control study. What is also very important to understand when we deal with bone strengths is that many factors are able to change and impair bone strengths. And for example, just simple parameters as age and sex will impair the relationship between stiffness, that is the parameters of the ductility of the bone, and strength. In fact, what this study demonstrates is that the balance between ductility and brittleness, that is very important for the biomechanical property of the bone, actually change over time, and it does so more obviously in female patient compared to male patient. Therefore, we end up with the data demonstrating that patients of the same age do not have the same strengths if they are male or female, while their stiffness is similar. And the decrease with aging is much more important in female patients compared to male patients. And the reason for that is that many components of the bone are very difficult to assess. And it is obvious that not only the mineral content, but also the relationship of the mineral to the collagen, the cross-linking of the collagen, all of these influence the bone strengths, and of course, so far it is very difficult to assess that, especially in clinical practice. Therefore, we need new tools. So the first idea is to evaluate the bone strengths with other technology, and that's the example of micro indentation. That is a very interesting and easy to use technique, and it has shown its ability to have a good prediction of fracture, especially in glucocorticosteroids osteoporosis. An alternative to that is to improve the fracture, the finite element analysis, and just show you this interesting study that do improve the this analysis by having fabric anisotropy that is mapped on usual anisotropy coming from PQCT data, and then mapped on QCT data. And that's important because we now have tools like the biomechanical computed tomography analysis that has demonstrated its ability using regular CT, especially in circumstances where CT are not used for this bone evaluation, and give additional information when on patient characteristics when they are performed. So it will improve the detection of osteoporotic patient at risk of fracture, especially when this kind of tool is used in an opportunistic way. There is also the issue of coming from the DEXA measurement and using software that is able to recreate the 3D evaluation of DEXA. And as an example, I show you this interesting study showing the differences in the changes of BMD in patients treated with DMAP compared to those treated with placebo in the Freedom study. And we may assume that this kind of approach will improve the assessment of our patient. And definitely, that's where the REMS will come in the future if its interest is confirmed. So if I just summarize this brief overview, it is important to define a person's biomechanical fracture threshold. Aerial BMD measured by DXA is still a fair assessment of bone strength. Numerous factors involved in bone strength have to be considered in this assessment. Added value of several imaging-based finite element analysis has been demonstrated. And we have now promising tools in specific circumstances to evaluate further bone strength. I thank you for your attention.
Today I'm going to present a radiofrequency echographic multispectrometry, basic principles and clinical evaluation. The outline of my presentation will include REMS technology, basic principles, then the outcomes of the clinical studies, and a conclusion. REMS technology is a novel technology that has been developed to measure the quality and quantity of bone, and has been introduced to overcome both the DEXA and peripheral ultrasound limitations. REMS technology is a unique and patented technology, being the first radiation-free technique available for the measurement of bone density. And the sites that are investigated with this technology are the vertebra and the femur, the same that are investigated in conventional DEXA. The bone mineral density estimation from DEXA and REMS is equivalent in terms of conceptual approach. In fact, the first step in the interaction of the X-ray on one side and the ultrasound beam on the other side with the bone tissue is the same. During this interaction, the ionizing radiation on one side and the ultrasound signals on the other side are partly attenuated and partly absorbed. And the resulting modified signal is detected by a dedicated sensor and translated into a quantitative value, the n-DEXA and the n-REMS. REMS technology allows to assess the bone status by performing a simple echographic scan of the spine. In particular, lumbar scan are performed by placing the echographic transducer in a transabdominal position under the sternum in order to visualize L1 lumbar and vertebra and then moving it up to the L4 according to the on-screen and audible indications provided by the device software EcoStudio. The echographic image in the slide shows a typical echographic image that can be seen during a lumbar scan. There are actually more vertebral interfaces visible, but each of them has to be located in the center part of the B-mode image. Each lumbar scan lasted 80 seconds, 20 seconds per vertebra, and for each completed acquisition, REMS technology is able to automatically acquire at the same time not only the sequence of B-mode images that is used as a guide only, but also the related unprocessed raw ultrasound signals. Immediately after the scan, an automatic processing of the acquired signals allowed to identify and analyze the target bone structure and the internal region of interest. Similarly, proximal femur scans are performed by placing the echographic transducer parallel to the head-neck axis of the femur in order to visualize the typical proximal femur profile, including the interfaces of femoral head, neck, and trochanter, as we can see in the figure in the slide. Once selected the proper combination of transducer depth and focus parameters, the operator can start the scan that lasts about 40 seconds and then wait for about 1 minute for the automatic data processing. The operating principle is based on the analysis of native raw ultrafiltered ultrasound signals acquired during the echographic scan of lumbar vertebra and of femoral neck. The analysis of native ultrafiltered ultrasound signals allows to retain the maximum information about the characteristic of the investigated tissues, which are normally filtered out during the conventional process of B-mode image reconstruction. The bone health status is assessed through the comparison of the analyzed signal spectra with previously derived reference spectra models for the considered osteoporotic and healthy conditions. This process allows to estimate BMD, T-score, and zeta score. In addition to this, the large amount of collected data related to internal bone structure provides both quantity and quality-related information, being thus theoretically suitable for the estimation of bone strength and the prediction of fracture risk. Since RAMS analysis is characterized by the parallel processing of the ultrafiltered signals of several scan lines, the analysis of single scan line spectra allows the automatic exclusion of signals corresponding to artifacts such as calcification or ossifies, thanks to identification of unexpected spectral features. And here the clinical study outcomes. This technology has been clinically validated. And the first validation step has been performed on samples of human femoral heads with using high-resolution micro-CT as a reference technique. For this purpose, human femoral head samples underwent two different examinations. On one side, each bone sample was insonified by a RAMS technology along 30 different transversal sections during its neck, head, and axis, and related bone mass values were then obtained. On the other side, the excited femoral head samples underwent a macro-CT scan in order to extract their local bone microstructure properties. Comparing the results of the two techniques, RAMS diagnosis showed a good correlation with the corresponding bone fraction volume computed through micro-CT. The RAMS technology was also highly correlated with bone quantity as measured through micro-CT, confirming its suitability for osteoporosis diagnosis. In the second clinical validation step, RAMS technology has been compared with gold standard DEXA. A multi-center cross-sectional observation study allows to deeply study and validate this technology. The results obtained by RAMS multi-center clinical trial has been shown in a very recent publication in Bone Journal, and the fact that this data have been published in such a prestigious journal means that they can have an important implication in our clinical practice. The aim of this multi-center clinical study was to assess the precision, short-term intraoperator, and the repeatability, short-term interoperator repeatability, and the diagnostic accuracy of the RAMS investigations in comparison with the gold clinical standard reference DEXA. Inclusion started in November 2016 and ended in September 2017, recruiting a total of 1,914 patients, all postmenopausal women between ages 51 and 70. Among them, 1,553 subjects underwent spinal measurement and 1,637 subjects underwent femoral measurement. Each patient underwent two different examinations, a spinal and the femoral DEXA and the RAMS scan of the same anatomical site. Specific attention has been paid to verify that all the DEXA and RAMS scans have been performed according to the corresponding guidelines for the correct clinical execution in order to assess the effect of possible errors on the diagnostic performance of RAMS in particular. All DEXA acquisitions were double-checked by two different experienced operators in order to avoid possible errors. And then DEXA results were assumed as the ground truth to assess accuracy of RAMS-based diagnosis. A quality control was performed on all the RAMS reports in order to verify the correct transducer depth and focus selection. The quality assessment on medical reports in the spinal group produced the exclusion of RAMS and DEXA errors, whereas several DEXA reports were reanalyzed and corrected. Analogously, in the femoral group, there were exclusions for REMS and DEXA errors and several reanalyzed DEXA reports. The resulting data set was 1595 for spine and 1373 for femur. Here we find the results of the REMS accuracy evaluation for each considered anatomical site in terms of sensibility and specificity assessment. Obtained data showed that REMS approach effectively discriminated the osteoporotic patients from the non-osteoporotic ones of both lumbar spine and femoral neck. The good diagnostic performance was confirmed also when the three possible classification categories, osteoporotic, osteopenic, health subjects, were considered. The diagnostic considerance between DEXAs and REMS was concordant for 88.8 for lumbar spine and 88.2 for femoral neck, respectively. In this context, it has to be emphasized that many of the cases classified as wrong classification are actually associated with borderline situations. And we accepted tolerance up to 0.3 on the REMS T-score value of borderline patients. And in this case, the diagnostic concordance would reach up to 97% for lumbar spine and 98% for femoral neck. So a very high concordance. These results are further emphasized by the high degree of correlation between the T-score values provided by the two techniques. In this slide, we can find the results referred to the lumbar spine, and the REMS femoral T-score also resulted very high correlated with the corresponding DEXA1, the correlation which is over 0.90. An important data to be considered in order to apply this new technology in the clinical routine is the evaluation of its precision and repeatability. Then the evaluation of precision and repeatability of REMS technology were also carried out. In particular, for each anatomical size, precision was assessed using the data acquiring for the first 5 patients enrolled in each of the 6 clinical centers involved in the study. Therefore, a total of 30 patients were used for precision calculation. Each patient underwent 2 consecutive REMS scans with patient repositioning between the scans. The same approach was used for repeatability calculation, and only the repeated measurements performed one by one experienced operator and the other by a newly trained one were included in the analysis. The calculation produced very good results. Precision expressed as RMIS-CV was 0.38% for lumbar spine and 0.32 for femoral neck, and the corresponding LCC values was 1.05 for lumbar spine and 0.88 for femoral neck, respectively. Analogous calculations were performed to assess repeatability, producing the following results: RMS-CV 0.54 for lumbar spine and 0.48 for femoral neck. This study assessed diagnostic performance of REMS investigations in comparison with DEXA in a multi-center clinical context. This data opened an important scenario in clinical practice. The evidence the REMS approach provides both sensitivity and specificity above 90% suggests that the proposed echographic method could be used to discriminate osteoporotic patients from non-osteoporotic ones. In addition to this, also when all the 3 possible classifications categories, osteoporotic, osteopenic, healthy, were considered, the diagnostic concordance between DEXA and REMS was over 90% for both spinal and femoral sides. The good diagnostic accuracy is confirmed by a very good correlation found between REMS-derived T-score values and corresponding DEXA results. Furthermore, for both the lumbar spine and the femoral neck sides, the precision parameters determined in the present study for the REMS approach were better than the corresponding values typically reported in the literature for the employed comparative gold standards. Thanks to this radiation-free approach, REMS could be applied for population mass investigations or prevention programs, early diagnosis in clinical practice, therapeutic short-term follow-up. So many applications in the clinical field. Since fractures are the main important osteoporotic effect on 3 million of fractures here in Europe, and these are caused by osteoporosis, the ability of REMS T-score in the identification of patients at risk for osteoporotic fractures has also been investigated. The results obtained in a dedicated clinical study has been shown in a very recent scientific paper published in the last March in Bone Journal. The aim of this study was to investigate the ability of the T-score values provided by REMS in the identification of patients at risk for incident osteoporotic fractures. 15-16 Caucasian women aged 39 years with a BMI lower than 35 kilograms per square meter underwent both DEXA and REMS investigation on lumbar spine and the follow-up period up to 5 years to assess the incidence of osteoporotic fractures. Afterwards, patients with and without incident fractures were stratified in 2 age-matched groups with a 1.2 proportion, Group A and Group B, respectively. The enrolled subjects were then divided into 2 groups, those who suffered an osteoporotic fracture during the follow-up period and those who did not. The performance of REMS and DEXA in fracture prediction was comparatively assessed by determining sensitivity and specificity in the identification of fractured patients when the typical BMD threshold for the diagnosis of osteoporosis was employed. After a mean of 3.7 years of follow-up, the incidence of osteoporotic fractures was 14%. Age-matched groups included the youngest 175 fractured patients and the oldest 350 non-fractured ones, respectively. The groups resulted also balanced for height, weight, and BMI. For the vertebral side, as expected, both the differences in DEXA and REMS T-score between fractured and non-fractured patients were statistically significant, with a p-value lower than 0.001. These results were substantially the same for the femoral side, where a statistically significant difference was observed between the 2 groups of patients. Considering the T-score cutoff of minus 2.5 for the vertebral side, REMS identified the fractured subjects with odd ratio of 2.6, whereas DEXA showed an ratio of 1.7. Similarly, for the femoral side, an odd ratio of 2.8 was measured for REMS, while an odd ratio of 2.6 for DEXA. REMS investigations on lumbar spine scans showed a good performance in the identification of patients at risk for incident osteoporotic fractures, and this confirms the potential of this non-ionizing approach for early diagnosis of osteoporosis and fracture risk estimation. To conclude, currently an international multi-center clinical trial called ECOBONE focused on the extended study of the REMS approach for osteoporosis diagnosis in a wide European clinical context through a head-to-head trial with DEXA. And this is currently ending in 5 reference centers for osteoporosis management. In general, the available data suggests that REMS technology might have a beneficial impact on current diagnostic protocols and subsequent patient management in the clinical routine. Further clinical scenarios are envisaged for additional REMS applications, including in particular fracture risk assessment in pediatric patients and pregnant women, and those in patients at risk of secondary osteoporosis. In addition to these, several ongoing clinical studies are being designed for carrying out short-term monitoring programs for the use of REMS technology for new clinical applications. RAMS approach has the potential to calculate also parameters different from BMD, derived from bone quality indicators, and further related to bone strength. Among those, the fragility score has been developed as an independent indicator of bone quality that provides an estimation of fracture risk independently of BMD. Ongoing developments of RAMS are addressed to the investigation of other musculoskeletal tissues such as muscle in order to monitor the onset and evolution of diseases like sarcopenia by early detecting the corresponding tissue deterioration to dedicated RAMS parameters. Thanks for your attention, and now I'm ready for the questions.